Wait, are we live?
No.
Good morning. Welcome back to House Healthcare. It's 10:24 on May 1st. I'm Representative Alyssa Black, my co-chair, Representative Tupper McFawn. And welcoming our chair from unknown destinations, but I think we're gonna so we're turning to H766 right now and looking at the Senate proposals of amendment. I think we're gonna have Jen walk us through the bill or the amendments. And I did ask Jen to kind of do maybe a side by side on section 3, because I wanted us as a committee, it's been a few weeks, I wanted us as a committee, a reminder of what we did before we looked at what the Senate did.
You want that first, or you want that?
Actually,
Changes.
let's do the changes.
Jay Harvey from the Office of Legislative Counsel, so I'm going to put up the Senate proposal of amendment. They did not do a strike all. So it is some instances of amendment. All right, so this is the Senate proposal of amendment. And they have 3 instances. The first is, it looks big, they're striking out section 1, which is the step therapy, but really they're doing that because they're adding something at the end. So the language itself that you did has not changed. They have just added on the end a new subdivision or subsection I and made 5J. That says a health insurance or other health benefit plan offered by a health insurer or by FPPM on behalf of the health insurer shall cover, without requiring prior authorization, at least one readily available asthma controller medication from each class of medication and mode of administration. And that's used in the subsection. Readily available means that the medication is not listed on a national drug shortage list, including lists maintained by the FDA and by the American Society of Health Systems Pharmacists. And that is the first piece of new language. So nothing changed in your section 1, but in addition.
Do we want to pause for if anyone has any, does anyone have any questions about that? And what we're
saying I and J, you can't.
Is this is this sent to us or?
I think the Senate proposal of amendment is posted under my name today.
This is on page 3,
Yes.
on the Senate
Right.
proposal of amendment.
So this is the first change.
This is the first change, is that, yes, so just for, because of where I was putting it, it made more sense to strike out section back into all of your language in it, but then add this subsection I. And so again, the idea here is that it's wordy, but without being as wordy, health plan has to make sure that at least one type of asthma controller medication from each class and each mode of administration is available is covered without requiring prior authorization. So they can't have one available without prior authorization, but it's on the national drug shortage list. That's what the readily available part is saying.
Yeah, and we had, I don't know if you remember, I think we had some providers testify sort of peripherally on this issue, but they testified in the Senate at a little bit greater length. And it was around, there was no readily available inhaler for kids because of the mode of administration.
Right, that's a great point. And so the language had originally been specific to pediatric use for under 18, and it was pointed out by GFR, right? That we're not allowed to make age-based discriminations in coverage under federal law. So we couldn't say just for kids, you have to have this, it had to be for all ages.
Yeah.
So
Sorry.
since it's not side by side, and I don't know the bills that well, that it's new language, that they added something, I is brand new.
I is brand new.
Okay.
Yep.
Okay, I guess we can move on to the rest.
Okay. The second instance of amendment is going into section 3. If you remember in section 3, this is on prior authorization and we were dealing with two subsections, C and D. They're only making changes in C. And I'll show you this in the side by side in a minute as well. So they struck out subsection C, that's the Medicaid alignment language that was required in prior authorizations to be aligned with Medicaid. And putting in instead a new subsection C, still striking out the same language you struck out that gets added back in D. But this would say, except as provided in subdivision B, which we'll see in a minute, a health plan shall not impose any prior authorization requirement for any admission, item, service, treatment, or procedure ordered by a primary care provider. And then the except part is the prohibition set forth in subdivision A shall not be construed to prohibit prior authorization requirements for prescription drugs, which you had also carved out when it was aligned with Medicaid, or for an admission, item, service, treatment, or procedure that is provided out of network. And that was another one of the carve-outs. And as used in this subsection, primary care provider has the same meaning as is used by the blueprint for health. And then the third instance amendment is really just a technical one, which is that I had used section 3 and then described section 4 in the effective date section. So this is saying it was really section 4, the timelines, the changed timelines for prior authorizations was what was in section 4, and that was the piece that the carrier said they needed some additional time for certain types of in-house processes that they needed to change their technology for. So confirmed that with stakeholders, and that was just the technical. Let me put up the side-by-side language if you want to look at that.
Does anyone want to see what we had previously? Yeah.
Here, and I showed this together minutes ago. I tried to get it so it would all be on one screen at the same time. So everything that's highlighted is where it's different between the two bills. So I just wanted you to be clear that this struck language at the top in C and this new.
We have it up to you.
Right? Because I have to share it, and just pull it up on the screen. Detail. Now you can see, so everything that is not highlighted is identical. Try to make the spacing work so you can see that. Everything that is highlighted is where the changes are. So in the version that passed the House, you had language expressing legislative intent to reduce variability in prior authorization requirements by aligning to the greatest extent possible with the prior authorization requirements in Vermont's Medicaid program. And then it said a health plan shall not impose any prior authorization requirement for any admission, item, service, treatment, or procedure that is more restrictive than the prior authorization requirements that DEVA would apply for the same admission, item, service, treatment, or procedure under Vermont's Medicaid program. And your language directed each health plan to review Medicaid's prior authorization requirements at least once every 6 months to make sure they are maintaining that alignment. And then it carved out, nothing in the subsection shall be construed to require prior authorization alignment with Vermont Medicaid for prescription drugs. So that's one of the concepts that was carried over. Or to prohibit prior authorization requirements for anything not covered by Vermont Medicaid. That's not carried over because it's not applicable to the structure the Senate had. Or to prohibit prior authorization requirements for an admission, item, service, treatment, or procedure provided out of network. So that's the other piece that carried over. Or require a health plan to maintain the same provider network as Vermont Medicaid. And that wasn't relevant in the Senate's construct.
We had a lot in
That's
there,
pretty
didn't
much-
we?
This is pretty much it. This is like myself.
This is the side by side. I just gave you section 3.
That's
So yes, that is all of the language in section 3 from both. I kind of reconstructed section 3. But didn't have to.
So this is the part that is, this is, the yellow is gone and it's being supplanted with the part you read to us about.
The yellow in the as passed by House.
Yes.
Yes, is
Is
struck and replaced with the yellow in the as passed by Senate.
Okay, all right.
Yeah,
Oh, yeah, no, go ahead, Art, and then Lori.
review for us for health definitions?
Yes, it's a, it's, yes, give me a minute to pull up where we were looking at it from, which is, no, but I can send it to you. I literally just,
Yeah, well,
created it.
so yeah, you're working fast.
Um.
I see Representative Houghton's hands up.
Helping out.
I am happily waiting. You can call on me last.
Following the correct procedure, Representative Luke has her hand up.
So I'm gonna first orient you to where we are, which I will do by sharing my screen. All right, so this came from the place I was sort of most easily able to find it in a list is in this Act 17 of 2019 report to the Vermont Legislature. This was where there was work done determining the portion of healthcare spending allocated to primary care. And there was a lot of work done on defining primary care in order to determine what the primary care spend was. So then we go to page 22, has a nice chart. So this is one of the appendices, they had a primary care provider and service definition comparison from lots of different sources. And one of those was the blueprint, and it seemed easiest from this list because it's not specified in statute to identify the provider types determined to be primary care providers under the blueprint.
So Jen, would every person could have a primary care provider, but a person wouldn't have 2 or 3 or 4, would they? I'm just trying to make sure I understand what we need. Like I go to someone and she's my primary care provider, as far as I know. But if I get referred to someone else because of a specific issue, that isn't.
That is a specialist
Okay.
that you likely that you'd be getting referred to. Now, you could be in a practice where you would, a patient of a practice where you would see a different primary care provider if your usual provider was not available.
Okay.
You can see that happening, so you probably wouldn't be specifically assigned as a patient to that person you're seeing in front of, but just honestly going on my own experience, when I try to get in to see my provider, they say, well, you can see this other one, tomorrow, or you can see yours.
Yeah,
I'm not
right.
So that's the only place I would see somebody likely having more than one primary care provider, or, if they're switching from one provider to another.
Right.
Within the same practice.
Well, or switching from one practice to the
Yeah,
other.
yeah.
So,
So this is from Blueprint?
this is this middle column here is the blueprint, which provider taxonomies are considered primary care under blueprint. Blueprint itself may have a clearer way of
Yeah.
that, wherever they sort of provided this information from, but we do not have that particular statutory definition that we just went to, so.
And Blueprint for Health Blueprint administers Blueprint for Health, which designates and attributes people to a primary care medical home. So you would only be attributed to one particular primary care at a time.
That would be my understanding.
Yeah, you'd never be attributed to. Representative Houghton, I hadn't noticed your hand up.
It's so hard to follow everything. I know. So Jen, I just want to confirm based on the side by side that the exceptions that we put in to ensure that prescription drugs and out of network care is still not factored into this bill. The Senate, although it's new language, the Senate kept those prohibitions.
That's correct. So that's why it starts with an except as provided in B, and then it says the prohibition in B says prohibition in A does not prohibit prior authorization for prescription drugs or or for out-of-network services.
Okay, and then in our past version, it was all healthcare providers. This is just primary care as defined by Blueprint for Health. So
That's
it's
right.
narrowed it. Okay, thank you.
It's narrowed this, right, it's narrowed the scope, but it's, I don't know the extent to which Vermont Medicaid imposes prior authorization requirements on items or things ordered by a primary care provider, so some differences in each direction.
So
Great.
in this version, in the amended version, essentially anyone who's not primary care is going back to the way of the world today, right?
Status quo.
Status quo so whatever prior auth requirements a health plan has today, if you're not a primary care provider, you would still be living in that world, right?
That is how
That's how I read it. Okay. Does anyone have any questions about it?
That's a lot of work.
Okay,
Only because when you say out of network, like, so I go into my primary care. A test is ordered, an MRI, okay, that's used somewhere everywhere. Is that out of network?
It's where it's being delivered.
If it's delivered in Boston, it might be out of net.
Right, but if it's living in Rutland where I live,
It'll
it
be in
probably
there.
is in that.
Yeah.
So
Likely,
those,
depending on the carrier and what the
right,
network
it
is like.
depends on a lot of things, I get it, but it could be, usually it would be in network.
Yes,
If it's following the plan. So those types of things, there would be no prior auth for any of that.
ordered by
Based
the-
on the Senate.
But yeah, right, under the Senate version, if your primary care provider ordered an MRI for you at a MRI, an imaging center that is participating in your plan,
Right.
then there would not be a prior authorization.
And that would occur on any service that was in network. Would be,
Anything, yes,
Something that
anything
would be-
in network that would be
all
prescriptive.
right, I just want to understand that.
And just for a little clarification, I remember a percentage being given. It was 90-something% of those prior authorizations were approved anyway.
I remember hearing that number, I can't tell you what the context was for that, if that was across all provider types or primary care providers only, or
Yeah.
maybe others who have more of a-
Art, did you have any other
Oh,
questions?
almost.
You said you had lots. I'm disappointed. All right.
In our conversation or?
Yeah.
John, or how do we?
Yeah, oh, absolutely. We'll have conversation. I think this was introduced, because this was a floor amendment and it was introduced as like an incremental approach. And I think I like that. Remember when we started this bill, I know it was a long time ago, but that section 3 evolved because we really couldn't find alignment, and it was Medicaid who came in and said our utilization didn't go up. And I think this actually makes it easier. It's cleaner. And the whole goal of, I think, this bill all along has been to try to align payers to, so that providers are working under the same rules. Everybody knows the rules, everyone knows how to play the game. And I like this because, we took a lot of testimony from primary care and, they're really overburdened. And I like that this just removes from them that, hey, now I don't have to even align with anything. I can just ensure that my patients are going to get the care they need. So And I appreciate the Senate's exceptions around prescription drugs and out-of-network. Daisy?
I think you make an important point about this, having potential to be like incremental, because there are other types of care providers who also are grappling with prior auths, and aside from them, it's really us, people that need that care, that have to wait for it or have to spend a year battling, trying to get the various stakeholders trying to get clarity on, how much are they responsible for and when can they get the care. This makes me hopeful that we can begin to look at the same issue across our system of care, ultimately getting people what they need sooner and getting all types of providers where they want to be with their careers, and it's not doing a bunch of paperwork.
Yeah, you reminded me, just today, and I think it was posted from another specialty saying, this is great, but what about us? And it's heartbreaking to come back to them and say, sorry, not this year, but maybe just doing it for this limited amount will be able to give us the data that we need, a year or 2 years from now to really truly see the impact. And then, then we can start making decisions about whether or not we want to expand it to other. I'm going to go with Art.
Yeah, and we probably had touched on this, but do we know what services align with Medicaid? We know what things don't require PA and do require PA in Medicaid, so we have a comparison.
Medicaid provided us with their
long list of,
a long list of
Okay, I remember.
they have an ACO covered service PA status list that they maintain on their website. And it's
Those are the things that don't require.
it's a list of every single CPT HCPCS code. One's in the book.
Okay.
And then they tell you whether or not prior auth is waived or not. I think that at the time they testified though, they waived requirements for advanced imaging. They no longer require anything on advanced imaging. Those are things like MRIs, CTs. I think they indicated that they had kept sort of risky behaviors, risky procedures.
They kept those.
They kept those.
Okay.
I'm sorry, I don't have their list
Yeah,
handy
no,
right
I know,
now.
that's fine.
I do remember that they,
I just, that would be significant now, is to compare, that's all.
I wish I could be able to, oh, I'm sorry.
Can I jump in? Sorry. I just also want to add to the comments that are being made about that. Let's remember that when we evolved Section 3 into the alignment with Medicaid, because Medicaid said, we've made a lot of changes the last couple of years due to COVID and utilization hasn't gone up. We did hear the counter from insurance companies that aligning with Medicaid would actually take them a lot of time, effort, and money. So I think this is a good balance, the Senate version, to say, okay, so we don't have to spend the time and money on aligning it, and yet we've narrowed it to just primary care providers. So to me, it's, we're giving away one and getting something else. It's a good balance.
Yeah, I agree.
That's what I was trying to say, but
Oh,
yeah. That's
But it'd still be good to know that list, that's all, I mean, I don't have it, I get we might not be
Yeah.
able.
It's probably on our webpage under Sandy Hoffman. I think there was categories provided, so it's out there.
I'm gonna call on Leslie. Martin.
Yeah, thank you. I know a lot of work and negotiation went into getting to where we are. I can't help but go back and I can't recall the name of the dermatologist who was here and really had struggled so much with prior auths. So taking out the specialists for me is a sad thing because they're spending a lot of time and effort, hours to get care for their patients. I understand the world is incremental. I would love a little more transformation, but I think we have to live with what we've got. But I'm not sure the world is changing for the insurance companies because that piece is gone, and that worries me. So, I'm just saying that because I think about, what was her name? I'm trying to remember the.
Dr. Lynn, I believe. Yeah.
Yeah, anyway, I thought her testimony was very poignant, and I have seen it happen in my own work, that patients would have to wait when they're dealing with specialists trying to get their care, and I think it's impediment, but I get that we're all where we are.
All right.
Just, I don't know that we need any more. I think we've all heard about the impact on the person needing care, but I'm gonna share it anyway. I've had a personal experience recently with testing that my provider, lots of experience and expertise, ordered, and the prior auth was declined, and the insurance company would only pay for this other kind of testing, which has a 39% misdiagnosis or has a track record of being inaccurate 39% of the time, which means I'm likely going to end up having to go back to the thing that my doctor ordered in the first place. So there's a delay of treatment. The issue that I have is I've been having to wait for months to get further along in my treatment with my primary care provider.
Yeah, don't give a-
Alan?
I have a concern that we've done this. We'll have other providers next year. We'll come back for some more. The one you're talking about and everybody else. And insurance premiums are definitely gonna go up. It's just an automatic thing. And I'm wondering if we're gonna price out the average citizen, that insurance costs are gonna be higher than the weight we have. So it's a concern.
Any other thoughts? All right, do we want to do a straw poll?
I move that we do a straw poll on H 766 as amended by the Senate.
All those that concur? Nine, and all those opposed? 2, 9 to 0. I think I'm-
You're better at the math than I am. Good job.
I practiced my additions ahead of time. All right, so I think this is on the notice calendar today, so it'll be up for action tomorrow, right?
Along with S98.
And S98. Great, so Maureen and I will. All right, well, thank you. And
Thanks, everyone.
we have 11 o'clock scheduled.